Dear colleagues, it's a great pleasure to contribute to this session. So I have a disclosure related to this topic. So as you know, we are frequently confronted to patients who have high gradient across prosthetic valve, and the differential diagnosis is much more complex than in patients with native aortic valve because there are several potential causes of increased gradient. The high gradient may be due to a prosthesis-patient mismatch, where in fact the prosthesis is generally functioning normally, but it is too small for the patient body surface area, so for the cardiac output requirements. Of course, the high gradient may be due to an intrinsic dysfunction of the prosthesis, such as an acute process, a thrombus, subacute endocarditis, or a chronic process, a pannus or calcific degeneration of a bioprosthetic valve. And there are other potential causes of high gradient that we have to keep in mind, such as, for example, in the case of bileaflet mechanical valve, you may have a localized high velocity, high gradient through the central orifice of the prosthesis. And finally, sometimes the high velocity or gradient is the only detectable sign of an occult regurgitation in a mitral prosthesis. So it is important to emphasize that the transvalvular flow pattern differ markedly in bioprosthesis versus bileaflet mechanical valve. In bioprosthesis, you have like in native valve, a nice circular orifice, and the flow velocity pattern is very similar. But in bileaflet mechanical valve, as you see, there are 3 orifices, and the central orifice is smaller. And so you may have a higher velocity within the central orifice, and continuous wave Doppler will pick this higher velocity, and you will overestimate the gradient, underestimate the effective orifice area. But this is an artifact. This is not a true dysfunction, of course. And this is what is well illustrated here by this 3D color Doppler image, where you see the higher velocity in the central orifice. And if you look at the guidelines, the 2009 guidelines of the American Society of Echo for the Doppler echo evaluation of prosthetic valve, and this is the algorithm they propose when you have a high velocity, a high gradient across a prosthesis in the aortic position. This algorithm is essentially based on 2 main parameters. The Doppler velocity index, this is the ratio of the velocity in the LVOT to the velocity of the transprothetic flow jet, so V1 over V2. And the other parameter is the shape of the velocity contour of the aortic jet by continuous wave Doppler. And when you have a DVI that is reduced, that is lower than 0.30 or even further lower than 0.25, and the velocity contour is rounded shape with a late peaking velocity, an acceleration time, so a time from beginning of the envelope to peak that is more than 100 milliseconds. This suggests prosthetic valve dysfunction, prosthetic valve stenosis. On the other end, if the DVI is higher than 0.3 and you have a triangular shaped velocity, well, then this suggests normal prosthetic function, and then you have to do the differential diagnosis between normal function with high flow versus normal function with prosthesis patient mismatch by calculating the AOA index for body surface area. However, the main limitation of this algorithm is that in particular, the flow shape, the contour, is highly dependent on the LV function and as well the chronotopy function. In this recent study, well, you see that if you want to separate a patient with normal function versus a patient with dysfunction on the right and patient with mismatch in the middle, well, with the gradient, there is a huge overlap between the 3 types of patients. And with DVI, you have a slightly better discrimination, but again, you have some patients overlapping. And same with the effective orifice area. And now, if we look at the acceleration time, which is a very important criteria in the algorithm of the guidelines, well, you see that it's even worse. And the acceleration time of 100 milliseconds obviously is not able to correctly identify the patients. Why? Because the acceleration time is highly dependent on heart rate. But then in this study, they showed that if you index, if you correct, if you will, the acceleration time for the LV ejection time, so the duration of the signal here, well, then you have you're able to better discriminate this patient with dysfunction. And a cut point value of 0.37 appears to be the optimal cut point. Another very important parameter to look at, of course, is the leaflet morphology and mobility. We need to look at the valve and not only at the hemodynamic parameters. And you have here a bioprosthesis with normal function. And here you see the leaflet that are thick and calcified with restricted opening. And here for a mechanical valve, bileaflet mechanical valve in the mitral position, here you see the normal function, and obviously here leaflets are stuck and there is a large clot burden. And on the other end, we know also that especially by transthoracic echo and even by TEE, it is sometimes difficult to image mechanical valve in particular because of shadowing. And in this context, cinefluoroscopy has been shown to be very useful for these mechanical valves to really confirm or exclude prosthetic valve dysfunction by measuring the opening and closing angles. And this is what have been used actually in this recent study published this year, where they use cinefluoroscopy to separate patients with normal function. This is the gray circle versus those with dysfunction, the red triangles. And you also have the patient with prosthesis, patient mismatch, the dark blue squares. And you see again that the gradient is not good to separate these patients. Effective orifice area, actually this is the index effective orifice area, not good either. Acceleration time, also a big overlap. With the DVI, Doppler velocity index, this is better, but still you have a substantial number of patients who are actually false positive. And then the two, in this study, the two best parameters to identify valve dysfunction were again the acceleration time divided by ejection time, and also interestingly, the difference between the AOA measured in the patient and the predicted effective orifice area, the predicted normal reference value of effective orifice area. And of course, the larger is the difference, the more likely is the presence of a dysfunction, and we'll come back on this interesting issue. So I think the message is that there is no perfect parameter, no perfect cut point, and we should use a multi-parametric approach to identify and quantify prosthesis dysfunction. So let's go through a few cases. This is here a 60-year-old man with a BSA of 1.95 underwent an aortic valve replacement with a Carbomedics number 19 3 years ago. After operation, he had a suboptimal evolution in terms of symptoms with persisting pulmonary hypertension. And this is the echo at 3 years. You see on this long axis color image some turbulent flow, mosaic flow, and high gradient with a mean gradient of 40. And of course, the question here is this a dysfunction? And this is a mechanical valve. This could be a thrombus or a pannus. Or is it prosthesis patient mismatch? Or it could also be, because this is a bileaflet mechanical valve, a localized high gradient within the central orifice. And of course, at this stage, we need more information. And I will present you the algorithm that we like to use when we are confronted to high gradient after aortic valve replacement. And in fact, this algorithm is a compendium of the algorithm of the guidelines and other algorithms that have been presented in the literature. What we find quite useful in the first step of this algorithm is to calculate the predicted indexed effective orifice area. How do we calculate the predicted indexed effective orifice area? Actually, you need to have the exact model and size of prosthesis that has been implanted, and with that you can get the normal reference value for this type and size of valve, which in this case is 1 centimeter square. And you divide by the BSA of the patient, which is 1.95 in this case, and you end up with a predicted indexed AOA that is of 0.51 centimeter square per meter square, which is small. So you can say now that there is mismatch, and actually this is a severe mismatch because the predicted index AOA is lower than 0.65. So you can tell without having done any measurements that when this patient left the OR, 3 years ago, we left the OR with a severe mismatch. Now, there may be something else because you may have a mismatch and a dysfunction. So the next very important thing to look at is the leaflet morphology and mobility. Again, we need to look at the valve. And if it is abnormal, of course, we need to consider dysfunction. And the other features that may be useful to identify, to detect dysfunction is when again, the AOA measured in the patient is substantially lower than the predicted AOA. And also, if you have a serial follow-up in the patient, it's always useful to have a good baseline echo and then serial follow-up. And you see a decrease in the AOA and DVI during follow-up, an increase in gradient, of course this is consistent with dysfunction. Now, on the other hand, if the leaflet morphology and mobility is normal or is undetermined because the imaging, again, is often difficult with prosthetic valve by transthoracic echo, this is where we look at the Doppler velocity index. And if it's lower than 0.30 and the valve is a bileaflet valve, such as the patient we are talking about now, well, the most likely diagnosis is this central localized high gradient, this artifact, if you will. But still, there could be a dysfunction. And in these patients, we do not hesitate to do a cine fluoroscopy. This is the best tool in this case to really discriminate the normal versus abnormal function. If it's not a bileaflet mechanical valve and the acceleration time over ejection time is higher than 0.37, we consider dysfunction and potentially other diagnostics tests. And if it's normal, then we check for technical error. On the other hand, if the Doppler velocity index is normal, is higher than 0.3, then we have to look for other potential cause of high gradient, high flow state, subvalvular obstruction, technical error, etc. So if we come back to this patient, well, the predicted AOA, as I mentioned, was 1. If we calculate the predicted index AOA, we can say that there is mismatch. And now if you look at the measured AOA at 3 years in this patient, it is 1.06. And actually, you see that this is perfectly comparable with the predicted, with the normal reference value of AOA. So the prosthesis here is doing what it should do. You can exclude dysfunction. And again, if you calculate the index AOA measured in the patient, well, it is about the same as the predicted. So the conclusion is that you have a severe mismatch here. And we of course, assess the mobility of the leaflet in this patient just to confirm that the function was normal, and this was the case. So this is a patient with pure, severe mismatch. And actually, this patient, because it was symptomatic and then persistent pulmonary hypertension, was reoperated. The function was obviously normal, and the function of the valve and the morphology. And the valve was replaced by a newer generation of mechanical valve implanted in a supraannular position, so we've been able to win one size, and the gradient was markedly reduced from 40 to 14 millimeters of mercury, and patient had a good evolution. Now, the other case is a lady with a BSA of 1.3, and here she underwent a mitral valve replacement 1 year ago with an onyx valve. So this is again a bileaflet mechanical valve. Her INR has been within target since the replacement, and actually she's asymptomatic. She is simply recruited for one of our research projects. And what we see at this research echo, nothing very spectacular, but gradients that are somewhat in the higher range of the normal range, and the measured AOA, the AOA measured by the continuity equation, because remember, the pressure half time method is not valid to measure the AOA in mitral prosthetic valve. You see the AOA by continuity here is small. So the issue, well, you may say, is mismatch an issue in this patient? Well, again, we're going to use the same type of algorithm. The only thing that is different for mitral valve replacement are the cut point. Severe mismatch is when the index AOA is less than 0.9, and mismatch overall is moderate mismatch is when it's less than 1.2. And the Doppler velocity index that we calculate is the inverse of the aortic. So this is velocity through the mitral valve divided by velocity in the LVOT. So it is abnormal when it is high, and the cut point is 2.2. And, well, if we come back to the patient, the normal reference value for the model and size of prosthesis that has been implanted in the patient is 2.2. If we calculate the predicted index AOA, 2.2 divided by 1.3 makes a 1.7. So you can say here that there is no mismatch. You can, with a simple calculation, say, well, this patient left the OR with no mismatch. Then the second question, because still we have somewhat higher gradients and small AOA, is there any dysfunction? Well, this is where it becomes important to compare the AOA measured in the patient to the predicted AOA, to look at this difference. And in this case, AOA measured is 1.1. Normally, the predicted AOA should be 2.2, so there is a big gap here, more than the measurement error. So still a matter for concern that we may have a dysfunction, but you still have one other thing in your differential diagnosis, which is, again, this central high velocity, because this is a bileaflet mechanical valve. So to address that, well, you need to assess leaflet mobility by TEE or fluoroscopy, or you can also use CT. But actually, in this case, by TTE, we had the answer. Obviously, you see a leaflet that is stuck here. And this was confirmed, of course, by cine fluoroscopy. And cine fluoroscopy, you also see some restriction in the closing of the other leaflets. So obviously 2 leaflets are of dysfunction. And going back to TTE with color, you see only a trace of regurgitation across this prosthetic valve. But if you do the TEE now, this is a different story, and you see a much wider jet. So it's at least moderate AR. So this is just to emphasize that the mechanical valve in a mitral position may cause a shadowing over the left atrium, and they may occult partially or totally the regurgitation. So when you have a doubt, it is important to do a TEE. So to summarize this case, this was a patient with obviously no mismatch, but a dysfunction, a mixed dysfunction with both obstruction and regurgitation. And what do we do with this patient? Well, obviously, she has an obstructive prosthetic valve thrombosis. The surgical risk is not high in this patient. She's stable, she's asymptomatic, so the option will be to look at the clot burden. As you've seen, the clot burden is not very large. So we attempted thrombolysis in this patient. Unfortunately, failed. So she underwent surgery and replacement of the valve. There was some thrombus, organized thrombus, and small pannus interacting with the hinge mechanism of the valve. The third case, very rapidly, is again a patient with 1 year post-MVR, again with a bileaflet mechanical valve, again asymptomatic. And here, what we were worried here because the gradient increased from the early post-op to baseline. And now we have, at 1 year, we have a mean gradient of 10, which is high for mitral prosthesis. DVI is also increased to 0.8, and the AOA by quantity is small. So again, we follow the same step and calculated the predicted index AOA. In this case, it is 1.1, so slightly lower than the cut point. We may say, well, there is some mild mismatch, but may not explain the high gradient in this case. And we compare the measured AOA to the predicted AOA, which obviously the measured AOA is much smaller than the predicted AOA, so we may suspect dysfunction. And finally, we assess leaflet mobility, here by 3D TEE, which provides a nice en-face view of the valve and showing normal mobility and no evidence of thrombus or pannus. So actually, the diagnosis that we conclude here, and we also did a cine fluoroscopy confirming normal function, is that it's probably a central localized high velocity. And actually, if you look at these images, you see the central and lateral jet. And if you believe me, you also may see the superimposition of 2 velocity envelope. And we may eventually say that this highest envelope in yellow reflects the higher velocity through the central orifice, whereas this one probably reflects the velocity through the central orifice and is closer to the true values of mean velocity. And if you use this envelope, you obtain normal gradients and AOA. So just to summarize these 3 cases, the first case that we've seen was a patient with high gradient, but actually there was no dysfunction of the prosthesis. There was a severe mismatch, and this patient had to be reoperated. And the 2 other patients are both patients 1 year post-MVR, both with bileaflet mechanical valve, and they are both asymptomatic. And this one has a slightly higher gradient, but actually had a severe dysfunction and had to be reoperated. And this one had higher gradient than the case number 2, but normal function and could be discharged. So this is just to emphasize that high gradient does not always mean prosthesis dysfunction. And vice versa, low gradient does not always mean normal prosthesis function. And again, we need a multi-parametric approach to identify this function. And the differential diagnosis between dysfunction, prosthesis patient mismatch, and other causes such as localized high gradient, as we've seen, is made by calculating the predicted index AOA, only a few seconds, comparing the measured AOA to the predicted AOA, assessing the serial changes in echo parameters during follow-up, and finally, importantly, evaluate leaflet mobility by TE or fluoroscopy. And in terms of management of this patient with high gradient, if it's localized high gradient, this is an artifact, so standard follow-up. If it's PPM, well, I think we need close follow-up and consider eventually reoperation if you have severe PPM and symptoms and or LV dysfunction, and you believe that symptoms are related to the severe PPM. So similar approach to native aortic stenosis. If there is prosthetic valve dysfunction and you suspect thrombosis, of course, you need to consider treatment, thrombolysis, or reoperation. Other dysfunction, close follow-up, and again, consider reoperation if dysfunction is severe and you have symptoms. And I refer you to these very useful documents, and thank you very much for your attention.
Thank you, Philippe, for this very nice presentation and the overview of this topic. Is there any question in the room?
I would have one question or one comment. I completely agree with you, Philippe, that the most important thing for the surgeon at the time of the surgery to implant the right size valve in terms of the orifice area of the implanted prosthesis. The only thing which is not necessarily covered is, and you're absolutely right, it's never possible to achieve a greater orifice area than a bigger orifice area than the prosthesis has by calculation or by how it is manufactured. But depending on how it is implanted from the surgical point of view, you easily can obstruct the prosthesis already during the time of surgery and cause early PPM based on the surgical problem during the implantation. So therefore, how often do you go back to the original early post-operative echo to compare this with your finding then 3 years later? From my point of view, that's one of the most important things to be done early after surgery, a good baseline echo, which you then can use for later comparison.
Yeah, I cannot agree more, Olaf. I think it's indeed, as I mentioned, the information that you have with the follow-up is extremely important, and I agree with you. You need a good baseline echo to have the good baseline reference. And of course, if you measure a gradient of 30 millimeters of mercury at 6 years post-op, and this 30 millimeters of mercury was already present at discharge, you may say, well, this is obviously a prosthesis patient mismatch and not an acquired dysfunction. So I agree with you. The only limitation is that sometimes, especially the pre-discharge echo following surgical AVR, the measurements of the AOA may be challenging because the patient is often hyperdynamic and the acoustic window is not good, and therefore it might be difficult to have a good measurement of the alveolar diameter. And so what we, in this case, the predicted AOA may be useful to have a first idea. And the other thing, in this case, what is actually recommended in the guidelines is to repeat the echo at 1 month. So if you think that your pre-discharge echo is not of a good quality enough to get a good baseline measurement of AOA, probably repeat at 30 days after the things have settled off and you have better acoustic window and the patient is less hyperdynamic and anemia has recovered, etc.
Maybe one question there.
Eva Gøsberg in Norway. Thank you for a wonderful talk. Sometimes with the fluoroscopy, it's really difficult to get the right angle to look at the valve prosthesis. And my question is, do you see any role for cardiac CT here?
Yes, thank you very much, Eva. Yeah, I think I didn't have time to show the data, but there have been some nice publication in the literature showing that CT indeed can be used for this purpose. And I agree with you. I mean, cinefluoroscopy looks simple when you show the images, but sometimes getting the right angle and the right images is not necessarily easy. So you need people who know how to do it. And yes, I agree. I mean, in our algorithm, this is our first line of imaging modality to do this. But CT may be used in patients where the cinefluoroscopy is not satisfactory. I agree, and that's another. I mean, and sometimes you have your answer with echo. I mean, sometimes with the TE, you see the dysfunction, but you also have with TTE and TEE, you may have some false actually negative, where especially when the dysfunction is symmetric, when it affects both leaflets, sometimes it's difficult to catch for the eye by TEE, and you may use cinefluoroscopy or CT.
Yes. Thank you much, Philippe, for the excellent talk.